India is facing a diabetes epidemic. One type of diabetes affects only pregnant women. Gestational diabetes mellitus, or GDM, is defined as glucose intolerance with onset or first recognition during pregnancy. Although around 1 in 10 pregnant women are affected by gestational diabetes, many people are not aware of the severe risks it can pose for both mother and child. Women who are overweight, older, have previously had a large baby, or have a family history of diabetes are more at risk. However, many women who are diagnosed with GDM have no obvious risk factors.
ಸಕ್ಕರೆ ಕಾಯಿಲೆ ಗರ್ಭಿಣಿ ಹೆಂಗಸರಲ್ಲಿ ಬರೋದ್ರಿಂದ ತೊಂದರೆ ಆಗೋ ಸಾಧ್ಯತೆ ಜಾಸ್ತಿನೇ ಇರುತ್ತೆ. ಯಾಕೆ ಅಂತ ಹೇಳಿದ್ರೆ ಮಗು ಮತ್ತು ತಾಯಿ ಇಬ್ಬರಿಗೂ ಕೂಡ ತೊಂದರೆಗಳಾಗುತ್ತೆ. ಇವಾಗ ನಾವು ತಾಯಿನ ತೊಗೊಂಡ್ವಿ ಅಂತ ಹೇಳಿದ್ರೆ ಪದೇ ಪದೇ ಅಬೋಷನ್ ಆಗ್ತಕ್ಕಂಥ ಸಾಧ್ಯತೆ ಇರುತ್ತೆ. ಅದಾದಮೇಲೆ ಅವರು ಅದ್ರ ಬಗ್ಗೆ ನಾಲೆಡ್ಜ್ ಕೂಡ ಇರೋದಿಲ್ಲ. ಅದಾದಮೇಲೆ ಏನಾಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ಸಿಸೇರಿಯನ್ ಸೆಕ್ಷನ್ ಜಾಸ್ತಿ ಚಾನ್ಸಸ್ ಇರುತ್ತೆ. ನಾರ್ಮಲ್ ಎಲ್ಲರಿಗೂ ಕೂಡ ನಾರ್ಮಲ್ ಆಗಬೇಕು ಅನ್ನೋ ಇದಿರುತ್ತೆ.
As nurses and midwives, you have a key role to play in the diagnosis and management of gestational diabetes.
ಗರ್ಭಿಣಿ ಹೆಂಗಸರಿಗೆ ಸಕ್ಕರೆ ಕಾಯಿಲೆ ಅಂತ ಅಂದ್ರೇ ಭಯ ಆಗುತ್ತೆ. ಮಾಮೂಲಿ ಅವರಿಗೇ ಸಕ್ಕರೆ ಕಾಯಿಲೆ ಅಂದರೆ ಭಯ. ಅದರಲ್ಲಿ ಗರ್ಭಿಣಿಯರಿಗೆ ಸಕ್ಕರೆ ಕಾಯಿಲೆ ಅಂತ ಹೇಳಿದ್ರೆ ಮನೆಯವರು ಯಾವ ರೀತಿ ರಿಯಾಕ್ಟ್ ಮಾಡ್ತಾರೆ ಅಂತ ಒಂದಿರುತ್ತೆ. ಅದಾದಮೇಲೆ ಮಗುಗೆ ಏನಾದರೂ ತೊಂದರೆ ಆಗುತ್ತಾ ಅಥವಾ ನಮಗೇನಾದರೂ ತೊಂದರೆ ಆಗುತ್ತಾ, ಇದನ್ನು ಹೆಂಗೆ ನಾವು ನಿಭಾಯಿಸೋದು, ಯಾವ ರೀತಿ ನಾವು ಅನುಭವಿಸೋದು, ಅದೇ ರೀತಿ ಭಯ ಇರುತ್ತೆ ಅವರಿಗೆ.
You are ideally placed to inform women about the importance of GDM testing in pregnancy and can provide timely support to women who are diagnosed with GDM.
ಡಯಾಬಿಟಿಕ್ ಚೆಕ್ ಮಾಡೋ ಪೇಷಂಟ್ ಬರ್ತಾಗ ಫಸ್ಟ್ ವಿಸಿಟಲ್ಲೇ ಒಂದು ಟೆಸ್ಟ್ ಮಾಡಬೇಕಾಗುತ್ತೆ ನಾವು, ಡಯಾಬಿಟಿಕ್ ಇದೆಯಾ ಇಲ್ವಾ ಅಂತ ಈಗಿನ ಪ್ರಕಾರ. ಸೊ ಅವರಿಗೆ ಕೌನ್ಸ್ಲಿಂಗ್ ಮಾಡಬೇಕು, ಈ ಥರ ಇದೆ, ಡಯಾಬಿಟಿಕ್ ಜಾಸ್ತಿ ಆದರೆ ನಿನಗೂ ತೊಂದರೆ ಆಗುತ್ತೆ ಮತ್ತು ಬೇಬಿಗೂ ತೊಂದರೆ ಆಗುತ್ತೆ, ಇರ್ಬೋದು ಇಲ್ಲದೇ ಇರ್ಬೋದು, ಆದರೆ ಈ ಪರೀಕ್ಷೆಯನ್ನು ಖಂಡಿತವಾಗ್ಲೂ ನೀನು ಮಾಡಿಸ್ಕೋಬೇಕಾಗುತ್ತೆ ಅಂತ ಅವರಿಗೆ ಕೌನ್ಸಿಲಿಂಗ್ ಮಾಡಿ ಅನಂತರ ಬ್ಲಡ್ ಟೆಸ್ಟ್ ಮಾಡಿಸ್ಬೋದು.
All pregnant women in India should be screened for GDM as part of routine antenatal care. The first test should be conducted in early pregnancy, ideally at the first antenatal care visit, with the second at 24 to 28 weeks.
ಹೇಗೆ ಅಂತ ಹೇಳಿದ್ರೆ ಎಲ್ಲ ಗರ್ಭಿಣಿ ಹೆಂಗಸರು ಹಾಸ್ಪಿಟ್ಲಿಗೆ ಬಂದ ತಕ್ಷಣ ಫಸ್ಟ್ ವಿಸಿಟಲ್ಲೇ ಇದು ಗ್ಲುಕೋಸ್ ಟಾಲರೆನ್ಸ್ ಟೆಸ್ಟ್ ಅಂತ ಮಾಡ್ತೀವಿ. ಆ ಟೆಸ್ಟಲ್ಲಿ ಏನಂತ ಹೇಳಿದ್ರೆ 75 ಗ್ರಾಮು ಗ್ಲುಕೋಸ್ ಪೌಡ್ರಿಗೆ 300 ml ವಾಟರ್ ಹಾಕ್ಕೊಂಡ್ಬಿಟ್ಟು ಕುಡಿಯೋದಕ್ಕೆ ಹೇಳ್ತೀವಿ.
Women do not need to fast for this test. It can be done irrespective of the time of the last meal. To reduce the risk of nausea, you should encourage women to slowly consume the sugar drink over 5 to 10 minutes. If a woman vomits within 30 minutes of drinking the oral glucose, the test should be repeated the next day.
ಅದಾದಮೇಲೆ ಕುಡ್ದಾದ್ಮೇಲೆ ಆಫ್ಟರ್ 2 hours ಆದಮೇಲೆ ನಾವು ಬ್ಲಡ್ ಟೆಸ್ಟ್ ಮಾಡ್ತೀವಿ. ಆ ರೀಡಿಂಗ್ಸ್ನ ತೊಗೊಂಡ್ಬಿಟ್ಟು ಇದು ಸಕ್ಕರೆ ಕಾಯಿಲೆ ಇದೆ ಇಲ್ವಾ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಕನ್ಸಿಡರ್ ಮಾಡ್ತೀವಿ.
If a woman's test result is more than or equal to 140 milligrams per deciliter, gestational diabetes should be diagnosed. If a woman's first test is negative, she must be tested again between 24 to 28 weeks of pregnancy. To begin with, women with GDM should be recommended to follow a 2-week program of dietary advice and regular physical exercise. For many women with GDM, these changes will be sufficient to keep their blood sugar under control. Make sure you also refer women diagnosed with GDM to field level A&M or ASHA for follow-up blood sugar monitoring. With gestational diabetes, maintaining a balanced diet is important. Women should be advised to eat smaller portions of healthy food, spread over 3 small meals and 3 snacks each day.
ಎಕ್ಸಸೈಸ್ ಏನು ಅಂತ ಹೇಳಿದ್ರೆ ಯೋಗ, ಧ್ಯಾನ, ವ್ಯಾಯಾಮ ಅಂತ ಹೇಳ್ತೀವಿ. ಮಾರ್ನಿಂಗ್ ಟೈಮಲ್ಲಿ ಜಾಸ್ತಿ ಒಂದು 30 minutes ಅಷ್ಟು ವಾಕ್ ಮಾಡಬೇಕು. ಈವ್ನಿಂಗು ಕೂಡ ಒಂದು 30 minutes ಅಷ್ಟು ವಾಕ್ ಮಾಡಬೇಕು, ಒಂದು ಶೆಡ್ಯೂಲ್ ಹಾಕ್ಕೊಂಡು. ಆ ರೀತಿ ಎಕ್ಸಸೈಸ್ ಮಾಡಿದ್ರೆ ವೆಯ್ಟ್ ಕಡಿಮೆ ಆಗುತ್ತೆ. ವೆಯ್ಟ್ ಕಡಿಮೆ ಮಾಡೋದ್ರಿಂದ ಆ ರೀತಿ ಸಕ್ಕರೆ ಕಾಯಿಲೆ ಕಡಿಮೆ ಆಗೋ ಚಾನ್ಸಸ್ ಕೂಡ ಇರುತ್ತೆ.
Many women will struggle to make lifestyle changes and they will need your support. You can help them to think about a small goal they can work towards. This could be walking for 15 minutes every day, perhaps after a meal, or it could be filling half their plate with vegetables at lunch or dinner. Taking small steps will build their confidence. Women must not be made to feel guilty if they fail to reach their goal. but should be encouraged to keep trying and stay positive. Women should return for a postprandial blood sugar test around 2 weeks after starting a meal and activity plan. If the test result is equal to or more than 120 milligrams per deciliter, refer them to a medical officer for medical management. If the level is less than 120 mg per deciliter, the pregnant woman can continue with dietary advice and physical activity only. Women with well-controlled blood sugar levels can be managed as per the high-risk pregnancy protocol, with a minimum of 1 antenatal care visit per month. If a woman requires medical management, a doctor will prescribe either insulin or metformin. Women who are prescribed insulin may be anxious about injecting themselves. You will need to show them how to do it safely. Women must be advised how to store the insulin and dispose of the needles. Ideally, women on insulin injections should regularly monitor their own blood glucose at home and record the readings. The doctor will advise how often this should be done. Some women will be prescribed a tablet, metformin, to take each day. Common side effects of metformin include diarrhea, nausea, stomach pain, heartburn, gas, and lactic acidosis. You should reassure women that any side effects are usually temporary. Women with GDM may experience hypoglycemia, low blood sugar. Women should keep glucose powder or tablets or a sweet food or drink close by at all times just in case. Following a treatment program for GDM can be challenging. Family support is key to making lifestyle changes that can be sustained. Encourage women to bring a family member or friend to appointments. Women with GDM should have their blood sugar tested at each antenatal care visit. The fetal heart rate should be monitored by auscultation at each visit, and regular ultrasounds should be performed to check fetal health and growth. You should refer women to a medical officer if any warning signs are present. If blood sugar is well controlled, delivery can take place at the usual health facility. Pregnant women with uncontrolled blood sugar levels or those with additional risk factors should deliver at a tertiary care facility. Where the baby is expected to be bigger than 4 kilograms, a cesarean section at 39 weeks is recommended. Women with GDM should be encouraged to start breastfeeding immediately after delivery, as this can help prevent the baby becoming hypoglycemic. Infants of mothers with GDM should be checked for hypoglycemia soon after birth, with capillary blood glucose testing conducted via heel puncture. Maternal glucose levels usually return to normal after delivery. Around 6 weeks after the birth, the mother must have a 75-gram OGTT fasting and 2-hour postprandial. If a woman's result suggests that she still has impaired glucose tolerance, you should refer her to a medical officer. Women with normal blood sugar levels at 6 weeks should be linked to the NCD program for annual diabetes screening. India is facing an uphill battle with gestational diabetes. But with continued community education, national testing and treatment, we can all work towards a positive difference for both mother and child.
ಇಂಡಿಯಾದಲ್ಲಿ ಈ ರೀತಿ ಗರ್ಭಿಣಿ ಹೆಂಗಸರಲ್ಲಿ ಸಕ್ಕರೆ ಕಾಯಿಲೆನ ತಡೆಗಟ್ಟಲಿಕ್ಕೆ ನರ್ಸಸ್ ಏನು ಮಾಡಬೇಕು ಅಂತ ಹೇಳಿದ್ರೆ ಮೊದಲನೇದಾಗಿ ಸ್ಕ್ರೀನಿಂಗ್ ಮಾಡಬೇಕು. ಗರ್ಭಿಣಿ ಹೆಂಗಸರಲ್ಲಿ ಯಾರಲ್ಲಿ ಸಕ್ಕರೆ ಕಾಯಿಲೆ ಇದೆ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಸ್ಕ್ರೀನಿಂಗ್ ಮಾಡೋದ್ರಿಂದ ತಡೆಗಟ್ಬೋದು. ಅದಾದಮೇಲೆ ಫಾಲೋ ಅಪ್ ಮಾಡೋದ್ರಿಂದ ಅವರಿಗೆ ಯಾವ ಟೈಮಿಗೆ ಬರಬೇಕು, ಯಾವ ಟೈಮಿಗೆ ಟೆಸ್ಟ್ ಮಾಡಿಸ್ಕೋಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಫಾಲೋ ಅಪ್ ಮಾಡೋದ್ರಿಂದ ತಡೆಗಟ್ಬೋದು.
ನಮಗೆ ಒಂದೊಂದು ಡೆಲಿವರಿ ಮಾಡುವಾಗ್ಲೂ ಮಗುವನ್ನ ತಾಯಿಗೆ ತೋರಿಸ್ಬೇಕಾದ್ರೆ ತಾಯಿಗೆ ಬರೋ ಸಂತೋಷ ತುಂಬ ಚೆನ್ನಾಗಿರುತ್ತೆ. ಮತ್ತು ಬೇಬಿನ ಮದರ್ನ ನಾವು ಸೇವ್ ಮಾಡ್ತೀವಲ್ಲ, ಅದೇ ನಮ್ಗೆ ತುಂಬ ಸಂತೋಷ.